Welcome to the Perry Health Pulse podcast, a program dedicated to taking you behind the scenes of healthcare, sharing firsthand knowledge from healthcare professionals, and putting you in the driver's seat on your journey to lifelong health and wellness. Listen and learn about how healthcare delivery is changing on our weekly podcast.
Thank you for tuning in to the Perry Health Pulse. Today we're going to be talking about Cologuard and colonoscopies. It's getting to be the end of the year. A lot of people have used up your deductible. It's a good time to go in and have those screenings done, but we want to talk a little bit about the difference between those. So we're bringing in two of our resident experts today. We've got Lisa Ackerman. She's the Director of Outpatient Services, and she's been working in special procedures for more than 15 years. And we've also got Dr. Faber from our Family Health Clinic. He's a board-certified family practice physician with over 30 years of experience here, and he's currently the clinic medical director. So thank you two for joining us.
You're welcome.
You're welcome.
All right, so first of all, we've all heard of colonoscopies. Doesn't really have the best reputation as something people want to do, but let's establish a baseline. What's the purpose of getting a colonoscopy and who should be getting them?
We recommend that you have a colonoscopy at the age of 50, unless, of course, you have a high risk, be like a family history of colon cancer, or you're having some symptoms that might constitute that you need a colonoscopy, whether it be abdominal pain, rectal bleeding, chronic diarrhea, or chronic constipation.
Main purpose would be to look for colon cancers or other colon disease, but primarily to screen for colon cancer because if you find it, it's a preventable disease or a treatable disease.
And how does the process for it work?
The process works by seeing your family doctor. You can actually probably just see your family doctor, and he can recommend that you have a colon screening. You meet with the GI doctor if needed. They set you up with the prep. The prep is the worst part, hands down, but we've improved the prep over time. There's probably 5 different new preps that aren't the old gallon that everybody remembers. You take your prep, which cleanses your colon, and you come in the day of your procedure, and there's sedation involved. So you're in like a twilight sleep, or we do have the ability to give you monitored anesthesia, which is a deeper sleep. It is just, it's a fiber optic tube that is inserted into the rectum that visualizes the whole colon, lets doctor view any abnormal tissues, remove any polyps, and the procedure takes anywhere from 20 to 30 minutes. You go to recovery for 30 minutes, and then you go home. You will be drowsy for most of the afternoon. We do advise that you don't drive, but the next day you can go back to your normal activities.
I'm really surprised it's that quick of a procedure with as much of a colon as people have. It's a big organ in the body, so I would think it would take a lot longer to look through it.
No, our doctors are really good. I mean, it really goes very smooth. We can do quite a few procedures. At Perry, we do them in the morning, and we start at 8, and most people are home by noon.
And I would add to that gastroenterologists, who are the specialists that generally do colonoscopies, are very efficient. Our gastroenterologists here are very efficient. I can attest to that personally. And things that would make it go longer, of course, is if they would find something untoward in the colon, such as polyps or structural things that would be precancerous, such as adenomas or cancer itself. That would certainly add to the time of the colonoscopy with needing biopsies and taking care in that. Having said that, if it's a screening colonoscopy, which we're very much encouraging for the people in the right age groups, in the right clinical situation, if there's really not much pathology or, for lack of a better term, bad things found, it usually goes very quickly and very smoothly.
With that, does the gastroenterologist always take the lead on the procedure, or is sometimes just the nurses who handle it?
No, this procedure is done by a physician. In speaking to Dr. Faber with abnormalities and things like that could arise during your colonoscopy, if there are polyps found, even if they are not cancerous polyps, we do remove those and we send them to pathology. A lot of times, if you're having some abdominal pain or chronic diarrhea, chronic constipation, we might take biopsies just to check more at a microscopic level to make sure that there's no abnormalities, like Dr. Faber had mentioned.
And with those polyps, those would be removed during the procedure?
They're removed during the procedure, yes.
Now, any more alternatives to colonoscopies have become a very popular thing. There's a lot of advertisements for them. Why is it that those are so appealing to people?
Well, there's no prep for those. There's no real dietary changes to take with the prep. You can do it at home. It's not invasive. Those are the three that I can think of.
I agree with that. The other thing that I would say is that I've practiced many years, and I find that some people are just adverse to the thought of that. And despite encouragement and what we know about screening for colon cancer, it's not infrequent for patients still to decline or refuse this, even in the face of good data that would indicate that you can certainly prevent more aggressive disease if you can find it early. I've always been one to try to encourage it, and as I alluded to earlier, I'm one who's been through it in a screening way and found it not to be nearly as unpleasant as a lot of people have thoughts about.
Now, Cologuard in particular is kind of the big one that's hear about a lot. You see a lot of commercials for it. Can you explain a little bit about how Cologuard works and why that might be so popular?
I actually had to study on this because we don't do a lot with Cologuard because I work basically in GI. I do suggest if, like with Dr. Faber, if people refuse to have a colonoscopy or they just don't want to do the colonoscopy and they aren't at high risk, something is better than nothing. But as far as how Cologuard works, I had to do some homework on it, so I'm going to let Dr. Faber explain that a little bit more.
What occurs when one is developing a precancerous or even a cancerous lesion is there's a genetic change in those cells of the colon. And what happens is they have developed the test, and the one that's out being advertised significantly right now called Cologuard tests for 11 different molecular changes in the DNA of those particular cells. They can then take those cells and give you a report back that's either negative, in other words, there was no DNA within those 11 molecular changes, or they can say, yes, there was a positive for one of those 11 molecules, and then that's when you would be, as a provider, sent the report from the company for Cologuard that says either, yes, it's positive, or it's negative. Obviously, if it's positive, that person should definitely have a colonoscopy done. But as Lisa was alluding to, if you have the test and you're not in a high-risk group, you come back negative, you have a reasonably, fairly high probability that you do not have any significant lesion in your colon. And as I understand it right now, it would be every 3 years that you would repeat it to have a reasonably good chance of preventing any kind of cancerous start from getting too large or too advanced within that 3 years. Obviously, as we age, things change and recommendations would change.
If my understanding is right, so cancer is a mutation of cells, so the DNA is changing. So with the Cologuard, from what I've seen, you do like a stool sample from home and you send it in, and that's trying to track those little changes in the DNA that might happen because of that mutation. Is that right?
That is correct.
And I'd like to just mention, you have to do it every 3 years. Let's say if you're 50, you have your colonoscopy, and you don't have any polyps, you don't have any abnormal tissue that needs to be evaluated, and you have no family history, you could actually be out 10 years before you have to have your next colonoscopy done. So that is an advantage to having a colonoscopy as opposed to the Cologuard.
Let's pause for just a moment to thank our sponsors.
Sometimes we don't notice how much our parents have aged until we come home for the holidays. All of a sudden, Mom is having trouble getting dressed and managing her medications. Perry Home Care, with its team of skilled nurses and therapists, can help keep your mom safe in her own home and get her health back on track. Talk to your mom about scheduling an evaluation with her primary care provider. Visit perrymemorial.org/homecare or call 815-875-4114 to learn more.
What about results? Is there a difference in the quality of results between the two?
Well, I mean, a colonoscopy, for one, is an actual visualization of your whole intestinal. We go clear to the cecum, which is as far as we can go in the large intestines. So that gives you the peace of mind that the doctors actually visualized your colon and not saw any polyps or needed any biopsies. You know, we remove the polyps, like I said previously, and if you look online like everyone does and Googles things, colonoscopy is still the gold standard of diagnosing and preventing colon cancer.
I would add to that with the Cologuard, the best I could find was that there's about a 13% false positive. Well, if you have a positive result, as I've already mentioned a little earlier, you're going to have a colonoscopy anyway. The likelihood of a trained endoscopist or specialist who uses the colonoscope, his false positive rate would be much, much lower because of the direct visualization that Lisa talked about. One must understand that the chemical tests will probably never reach 100% effectiveness, and one could argue that even in the best of hands of gastroenterology specialists, something could possibly be missed, but it's much less likely with a colonoscopy than the Cologuard.
Well, and to add to that, even you mentioned that they can take out the polyp right then during the procedure, which is not going to happen for Cologuard.
And another advantage of the colonoscopy is I don't directly use them anymore, but the equipment continues to improve. Think about your televisions that went from 3K to 4K and how much better you can see things. And I think we mentioned earlier, too, that preps are the most scary thing for some people, but you don't have preps now that require nearly as much volume to drink, and it's much easier for people, even people who don't think they can drink that much.
I completely agree.
What would be a high risk or something where a patient might have a higher risk of developing colon cancer that you'd really want to get them in for the colonoscopy?
Let's say an example would be myself. Let's say my mom was diagnosed with colon cancer at 50, which would be, not a standard normal situation. We would explain that if your parent was diagnosed with cancer at 50, then we go back and you should have yours 10 years prior to when they were diagnosed. So if you have a family history at an early age, then your siblings or your children should be tested 10 years before yours was diagnosed.
Other examples would be people with inflammatory bowel disease. There'd be no point in doing a Cologuard on those folks. You'd want to continue to follow with your gastroenterology specialist for routine follow-ups depending on how those diseases are clinically progressing or not progressing. Those would include things like Crohn's disease or ulcerative colitis. And there are, above and beyond early colon cancers in families, there are some genetic mutations where they can get colon cancers and polyps at a very, very young age, even down into the teens. Those persons certainly wouldn't be candidates for Cologuard.
Is there a point where people no longer really need to get screened? Maybe they've reached an age or they have no risk and no family history and they just don't need to get screened anymore?
We have people that are elderly, maybe in, let's say, you're in your 80s, 80, 85, and you had a clean colon, and you've had clean colon 10 years prior. When you're 80 or so, doctor would suggest that you repeat it in 10 years. More than likely, those people are going to decline, or they'll say, we have a lot of them say, well, we're not going to come back. It's still a good rule of thumb to have, but definitely when you get higher in age, people sometimes decide not to have the test repeated.
There's a situation where there's not just the chronology of a person's age, but what their medical conditions are. If they have other intercurrent or severe medical conditions that would limit their suspected longevity, one might not do a colonoscopy because the odds of them finding something in the colon that would be life-threatening may be well less on their other medical conditions, such as COPD, which is a severe lung disease, heart disease, such as heart failure. And those people may be at an age where you might think about doing a colonoscopy, but their other medical conditions would preclude doing it.
And Dr. Faber, from what you've seen with the patients that you have come in, is there a tendency to be nervous or scared about getting a colonoscopy done because they're scared to actually find something?
I would say that's not the biggest reason that I have patients decline or refuse or become very hesitant to have a colonoscopy. I won't say that that's never happened. I've had people look me in the eye and say, I don't want you to find anything. That's true. Most of them that I find over my many years of practice just simply don't like the idea of it. They think it's kind of crude and an invasive procedure. And some of them simply don't think they have any symptoms. If they don't have any symptoms, why should I have a test?
Now, to wrap this up, you've both kind of touched on it a little bit, but I do want to give the listeners one more overview of how the process works here at Perry, starting with a visit with a primary provider and through how all of that would work. Starting with Dr. Faber, can you explain how that starts?
Yes, I would explain to a patient that they're at the appropriate risk area in their life regarding their age, their overall health, to have a screening colonoscopy. Most people have an idea of what it is, but you would explain what it is. And when they agree to the screening, I make a formal referral to the gastroenterology specialist. And as I understand from screening, they need to see the gastroenterologist first. They go through explaining to them again what they do. They get them set up for the prep, which we've talked about a little bit before. And then they get scheduled to come into our special procedures unit. And this is where Lisa would take over more than my job would be. My job is to get them there and encourage them and explain to them the need for it. Usually the gastroenterology specialties and our endoscopy unit here or special procedures unit will take them after they've been set up to come and register into the hospital for their procedure.
And then our department, once you've been scheduled for your procedure, my staff actually contacts you 3 days prior to your procedure just to review your medical history, your medications, any questions that you might have concerning your procedure again, because we really want to make sure that you have all your questions answered before you get here the day of your procedure. The day of your procedure, of course, you need to bring someone that can drive you home. We get you down into the room, do a quick assessment. You have to sign an informed consent because it is an invasive procedure. We do start an IV because, like I said, we can give you medications through the IV that help you drift off to sleep. And then, like I said, you have your procedure, you recover, and then you're able to go home. Our biggest thing when you leave Perry is that you don't drive for 24 hours because of the sedation that you've received. After your procedure, my staff does go over with you your findings. The physician is available to talk to you if you prefer. A lot of times they don't because you've had the sedation and they talk to you and then you don't recall that they have. But they are available to talk to you following your procedure. We do send a copy of your report to your family physician, whether it be Dr. Faber or someone else. And everything's sent to lab, and then you have a follow-up appointment with the GI doctor in their office.
If results aren't good, I usually get an actual call from Dr. Dorn or Dr. Naravati or some kind of personal contact. This is what I found. I've explained it to your patient. They'll be coming in to discuss it with you as well. If it is completely normal, I would say the patient may just want to come in and touch base about it because they were a little groggy at the time and just wanted to touch base because you've been their primary care provider for many years. And other times, the patients really, if it's normal, that's what they want to hear and they're happy about it, and they'll more than likely comply with the routine screening of having had a normal colon and be very satisfied with the results.
I'd like to touch base just on if you do have, let's say you do have a bad outcome in our department. My staff is very knowledgeable to get you scheduled for the tests that need to be done prior to you actually even leaving that day. So it's not something that we sit back and we wait on. We definitely are proactive if your outcome isn't what was expected or you do get maybe bad news. We want to make sure before you leave Perry that you have all your questions answered on what the next step is if you do get an unexpected or a bad diagnosis in our department.
Very good. So lots of great points that were discussed here. What I'm going to try and do is put a little bit of a summary of a lot of the benefits of colonoscopies on the webpage for this episode. If you go to www.perrymemorial.org/podcast, this is going to be episode 25. You can find information about our guests and about this episode. It sounds like there's some really, really good reasons to opt for the colonoscopy rather than Cologuard or other alternatives. So something to keep in mind, and check in with a primary care provider to make sure that you're getting the tests done that you need. So Lisa and Dr. Faber, thanks so much for joining us.
Thank you.
You're welcome.
It doesn't stop here. Access other podcast episodes and resources related to today's episode by visiting www.perrymemorial.org/podcast.